Hello and welcome to Pulmonology Read Aloud. This is Dr. Anjumaneja Arora back with another read aloud of a guideline. This time it is a combined joint guideline by American College of Rheumatology and ACCP on treatment of ILDs in people with autoimmune rheumatic diseases. This is a very important guideline because treatment of autoimmune diseases is a gray zone where often the rheumatologist and chest physician may not have a common consensus. So, this guideline paves the way for evidence based management of autoimmune diseases. Let's get started. So, what are the interstitial lung diseases which are covered in this guideline? So, this guideline paper includes the diseases which come under the umbrella of systemic autoimmune rheumatic diseases. These are the ones which have ILD as a greatest risk factor. So, these include systemic sclerosis, rheumatoid arthritis, inflammatory myopathies, which include polymyositis, dermatomyositis, antisynthetase, MCTDs or mixed connective tissue diseases, which may have a combination of various factors which may be positive, and Sjogren's disease. The guideline statement comprises of 35 recommendations, of which 2 recommendations are strong recommendations and both are regarding systemic sclerosis. They discuss 3 different aspects of ILD treatment in SART, which includes the first line treatment one would start, secondly, what should be the treatment if there is a progression, and third, what should be the treatment if there is a rapidly progressive ILD in these conditions. Starting with the first flowchart, which is a very well defined flowchart, which talks about initial treatment options in patients of SARD ILD. Have a look first at the glucocorticoids, which are usually started in most ILD patients by chest specialists. There is a very strong warning here that we should not start glucocorticoids as the first line treatment in systemic sclerosis ILD. In all other ILDs, you can start short term glucocorticoids as the first initial treatment. However, never start that in systemic sclerosis ILD. There's a much higher incidence of scleroderma renal crisis. So the guidelines have this as first strong recommendation against glucocorticoids. In the other diseases, short-term glucocorticoid would mean any therapy which is less than 3 months. And here, oral prednisolone has been recommended to be started. They do mention that IV methylprednisolone is typically reserved for an acute onset or severe ILD. Also, certain cases where you may have more of fibrotic component, like in rheumatoid arthritis, if there is UIP pattern, some panelists were of the opinion that you may not want to start glucocorticoids. Remember, it mentions short-term glucocorticoids. So long-term glucocorticoids is not advised, and it has been seen that even in MCTD ILDs with systemic sclerosis phenotype being as a component, any glucocorticoid above the dose of 15 milligram or equivalent prednisolone per day could increase the risk of scleroderma renal crisis, so it should be avoided. There is a good moderate certainty of evidence of harm, and there is no clear evidence of efficacy when you start glucocorticoids in systemic sclerosis. So this has led to this recommendation. The other group that's mentioned here is first line ILD therapy. The first line ILD therapy group that they have mentioned is a hierarchy based note which they have mentioned based on the number of votes that each therapy got from the panel, and this has further been divided into the preferred group and the additional options. So one should try to choose from the preferred group and then add additional options if needed. The preferred group for most of the ILDs, like you see here, is mycophenolate. So mycophenolate has been conditionally recommended over all the other therapies in almost all SARD ILDs. Further, the therapies are divided into preferred and additional. So if you look at the other drugs other than mycophenolate, rituximab is included in almost all of these ILDs. Azathioprine predominates all except systemic sclerosis, where it has been moved to additional. When we talk about additional options, cyclophosphamide exists for all of the SARD ILDs as additional option. Now here the panel group clearly mentions that cyclophosphamide has been shown to stabilize FVC, to also improve the outcomes. However, because of its higher side effect profile and mycophenolate being a less adverse effect drug, they have kept mycophenolate as the preferred compound, and cyclophosphamide, even though its outcomes are similar, has been kept in the additional options. Mentioning about rituximab, there is a good evidence from almost 4 big trials and observational studies in systemic sclerosis, rheumatoid arthritis, and myositis also, that rituximab results in improvement, it results in stabilization of FVC, and the guideline group specifically mentions that if you have the setting of inflammatory arthritis, for example, in rheumatoid arthritis, myositis, or Sjogren neuropathy, then this group, these patients, rituximab may actually do very well because of its effectiveness in treating these manifestations. However, they've also mentioned that we need to be careful about the infection risk, the cost, and impact that it may have on immunogenicity of vaccines. So, overall, most of these groups, mycophenolate could be a safe option, and cyclophosphamide could be an alternate option, keeping in mind the side effect profile. Another thing that you can see here is azathioprine, where the voting panel had actually supported azathioprine as a first line across the diseases except SSc-ILD, where it's kept additional and not preferred because we have limited evidence on effectiveness related to the other therapies that SSc-ILD would better perform with, like mycophenolate. Also, 2 groups of drugs. The calcineurin inhibitors and JAK inhibitors have been reserved for myositis, which have been included as the first line therapy or the additional option. So, 2 main points coming out of this. For people with SARD ILD other than SSc ILD, we conditionally recommend glucocorticoids as the first line allergy treatment, can be done short term. And for people with SSc-ILD, strong recommendation against glucocorticoids as the first line ILD treatment. Coming to the use of tocilizumab. So here, especially in 2 conditions, which is systemic sclerosis and mixed connective tissue disease ILD, there is a conditional recommendation of tocilizumab as the first line ILD treatment in systemic sclerosis and as the additional option in mixed connective tissue disease. Now, this has come after studies which have shown FVC stabilization in 2 big trials of systemic sclerosis compared with placebo. And since tocilizumab has had a better adverse event profile as compared to cyclophosphamide, it has been given a higher preference in systemic sclerosis, and this is particularly again for those phenotypes which have more inflammation, so elevated C-reactive protein, or those who have skin thickening or early diffuse disease. It will actually perform better than cyclophosphamide, so it's recommended as an additional as the preferred option here. And in MCTD-ILD, especially for patients with SSc features, it would be preferred as a additional option. What are the drugs that are recommended against? So the group says that leflunomide, methotrexate, TNF-alpha inhibitors, and abatacept are to be avoided. So there is a conditional recommendation against initial treatment of SARD-ILD with any of these groups. Now, leflunomide is a very commonly administered drug in rheumatoid arthritis, but there have been studies that have noted a development of ILD or worsening of ILD in certain rare cases with leflunomide. So there is an uncertain benefit on the ILD outcomes, and we don't know whether it will worsen it. So if a patient with ILD is on leflunomide, the panel recommends against it in the initial management. Also, methotrexate has been rarely been associated with idiosyncrasies, pneumonitis, and whatever observational data is present does not show that methotrexate can progress existing ILD. However, there was a panel which mentions that if a patient on methotrexate, for example, with extrapulmonary manifestations, is receiving it, some panelists in the group discussed that methotrexate should be stopped. So methotrexate should be stopped in the presence of an ILD while on methotrexate, according to some panelists, and also some of them mentioned that it should be stopped if there's a concern of methotrexate pneumonitis. So the evidence is still lacking. So do not start it upfront if you are starting the treatment in SARD ILD. Abatacept, again, studies have not suggested worsening of ILD, so discontinuation ideally is not necessary, but the effect is uncertain. There is no beneficial effect, so the panel has advised against it. Coming to antifibrotics, it's commonly seen that a lot of times antifibrotics are added to immunomodulators in an effect to reduce fibrosis, progression, and to halt the progression of ILD. But the panel clearly mentions that if you talk about antifibrotics, then in systemic sclerosis ILD, one may consider adding nintedanib as an additional component to the immunomodulatory therapy. But if you look at all the other ILDs except systemic sclerosis ILD, the recommendation is against nintedanib. When we talk about rheumatoid arthritis ILD, they could not come to any consensus on antifibrotics. And for pirfenidone, the conditional recommendation is against pirfenidone as a first-line ILD treatment because we do not have good evidence. The evidence for nintedanib also in SSC ILD is low, so this is a conditional recommendation. And they also mention that nintedanib may just cause an attenuation of the FVC decline and not stabilize the disease or improve the disease. So there's lack of efficacy in these parameters. So immunomodulatory therapy will be our obvious first choice. But if you are adding nintedanib, it would be an additional rather than a preferred option for the first line treatment. As regarding Sjogren's disease, MCTD-ILD, the efficacy of these is limited. Again, immunosuppressants will be our first line. Only when you see UIP, you may want to start nintedanib in these groups, irrespective of whether they have SARD or not. So that has to be seen on a case-to-case basis. What about the combination of MMF and antifibrotics? So, MMF specifically, the recommendation is that we must not add nintedanib or pirfenidone to MMF in SARD ILD receiving MMF if there is no ILD progression. So, if you do not define progression, do not start antifibrotics. Conditionally, they also recommend against upfront combining antifibrotics with MMF over MMF alone. So do not start both together as an empirical management. Start only if there is an evidence of progression, but then also they would prefer us not to combine both of these. So both the role of sequential combination therapy of nintedanib or pirfenidone after MMF in the absence of progression and upfront therapy is to be avoided. Only if there is a progression documented, you may consider antifibrotics. Coming to the group of ILDs, as mentioned, two special agents, JAK inhibitors and calcineurin inhibitors. So JAK inhibitors like baricitinib, tofacitinib, which is available in our country, and calcineurin inhibitors like tacrolimus, they can be added as the first line ILD treatment in this group of patients. Regarding stem cell or lung transplant, they recommend we should first do medical management and then only consider stem cell or lung transplant as the first line option. Also, that has to be considered only in those centers who have a strong experience to assess the ILD and positive outcomes. Coming to the second part of the treatment, which is progression of ILD. So here they've defined progression as according to the inbuilt trial criteria. What are these criteria? They include that a patient should have a decline in FVC of more than 10% in the last 24 months, or a decline in FVC 5 to 10% in the last 24 months with either only worsening of symptoms, 2. Increasing fibrosis on chest CT, or worsening and fibrosis within the last 24 months, then we would say that this ILD has progressed. So if the ILD has progressed, what do we do? So if you had started the patient on first line ILD therapy, then if your ILD is progressing, you can add another therapy or you can switch therapy. Now here again, what's important is the consideration of glucocorticoids. There is a very, very strong recommendation, and this is the only second strong recommendation where long term glucocorticoids are not to be given, even if there is a progression of systemic sclerosis ILD. So strong against, and in other other SARD ILDs, conditionally again they recommend against long-term glucocorticoids, which is more than 3 months. So that is the first thing. If the ILD is progressing, do not continue glucocorticoids. And if it's systemic sclerosis, definitely do not continue long-term glucocorticoids. Referral for lung transplant evaluation at the appropriate time is a conditional recommendation which comes with severity of the disease and progression of the disease. Now let's look at the therapy options. The therapy options are, for systemic sclerosis, patient is on mycophenolate, you can do switch therapy to rituximab, or remember you can add therapy. So mycophenolate, rituximab, nintedanib, obviously if there's fibrosis, tocilizumab, cyclophosphamide, and hematopoietic stem cell transplant referral. They are all the options of therapy at progression. For myositis, the options are same except calcineurin inhibitors, IVIG, and JAK inhibitors stay in this group. For MCTD-ILD, again, IVIG is in addition to what systemic sclerosis is offering. Rheumatoid arthritis, pirfenidone over nintedanib, so both are mentioned here. And Sjogren's disease, mycophenolate, rituximab, nintedanib, and cyclophosphamide. In a nutshell, long-term steroids, more than 3 to 6 months, should not be relied on for treatment in progressive ILD. That is something to remember. So broadly, what are the options then we have in progressing ILD, which is progressing despite therapy? You add or switch to MMF, rituximab, cyclophosphamide, and nintedanib addition, or pirfenidone in case of rheumatoid arthritis. These are the options one has with them. In case of patient who's on MMF, you can switch to MMF, continue on progression. This is recommended over the others. So that really means that if the patient was not an MMF, then the switch to MMF is recommended. So you can continue that and add on. You can add on rituximab. Rituximab can be given either as an add-on to the MMF or as a switch only to SSC-ILD, MCTD-ILD, IIM-ILD, RA-ILD, and Sjogren's disease ILD. In these scenarios, you can add rituximab to MMF or you could switch it. Cyclophosphamide has shown a favorable profile from indirect trials, so it can be switched to in SSC-ILD or RA-ILD. It has a favorable outcome as a second-line agent despite its adverse reactions. So systemic sclerosis and rheumatoid ILD not stabilizing on MMF, you don't want to give rituximab, cyclophosphamide can be added. In case of nintedanib, we usually add it rather than switch to it only in progressing fibrosis on CT scan. But the concern here is it will only slow the FVC decline. So immunomodulatory must continue and there are GI side effects that have to be taken into consideration. In terms of antifibrotics, as I mentioned, something that is changed from the first line treatment is the role of pirfenidone in RA-ILD. So the only place where they have recommended pirfenidone is rheumatoid arthritis included induced ILD in progressive phase. In all other ILDs, the conditional recommendation is against pirfenidone. Tocilizumab is recommended in systemic sclerosis, mixed connective tissue disease, and RA-ILDs. It is not recommended in Sjogren's disease and IIMs in progression. It is preferred if patient has early progressive SSC-ILD with diffuse skin involvement, increased inflammation. How do we measure that? With acute phase reactants, and in MCTD-ILDs, it is recommended only if there is SSC phenotype. So let's glance at this figure again. In IIM-ILDs, in myositis ILD, the only condition for adding calcineurin inhibitors and JAK inhibitors and IVIG, some role of IVIG in MCTD-ILD, and there is a recommendation against plasma exchange in any of the ILDs. The last group that has been defined is the group of rapidly progressive ILDs. The panel acknowledges that there's a lot of confusion regarding rapidly progressing ILDs. It's often confused with acute interstitial pneumonia, and they reiterate that any ILD in which a patient was earlier better with good oxygenation or maintained oxygenation but now has worsened or increased oxygen requirements or ventilatory requirements in days or weeks without any evidence of a known cause could be termed as rapidly progressive ILD. When we look at the treatment of rapidly progressive ILD, it's basically based on how severe the disease is and also on specific subtypes. One of the subtypes that has been mentioned here is the anti-MDA5. So anti-MDA5 is actually anti-melanoma differentiation gene, which is a rare subtype of dermatomyositis which is characterized by rapidly progressive ILD and dermatomyositis rash. So this flowchart mentions that if a patient has a severe disease or has a high suspicion of anti-MDA5 based on his presentation, then after IV glucocorticoids, which will be the initial treatment, we have to add upfront combination therapy with two more additional therapies. So here becomes a case for triple therapy for such patients. So whatever the patient was on, along with that two additional therapy out of the basket of rituximab, cyclophosphamide, IVIG, mycophenolate, calcineurin inhibitor and JAK inhibitor. Also, we need to consider early lung transplant referral. If this patient does not have anti-MDA5 or the disease is not that severe to start with, then in that case, after IV glucocorticoids, one can add one more or two more additional therapies. So here it is usually a double or a triple therapy, and here the options remain the same: rituximab, cyclophosphamide, IVIG, mycophenolate, calcineurin inhibitors and JAK inhibitors. It's also mentioned that the IV glucocorticoid that has to be administered has to be preferentially pulse IV methylprednisolone first line, and that will be followed by high dose oral prednisolone. Other immunosuppressants have to be administered along. Sometimes there may be overlap, like in MCTD. There again, the immunosuppressant of the first choice has to be chosen accordingly. When we talk about cyclophosphamide, because of the severity of the disease, again IV will be preferred over oral, and cyclophosphamide will be preferred over MMF and azathioprine in rapidly progressive cases. The recommendation also refers against methotrexate, leflunomide, azathioprine, TNF inhibitors, tocilizumab, nintedanib, and plasma exchange in rapidly progressive ILD type. Coming to additional integrative therapy, pulmonary rehabilitation will have a strong role, so will vaccination, physiotherapy, and palliative care. To conclude, in case of SARD ILDs, MMF is usually generally favored first line ILD treatment for all SARD ILD diseases. We must consider patient factors and choose from the menu of choice given as per this guideline. Rheumatoid arthritis ILD with active inflammatory arthritis may perform better with rituximab as compared to MMF. There's a strong recommendation against glucocorticoids use in SSc-ILD as a first line. In all others, you may give short-term glucocorticoids up to 3 months only. In rapidly progressive ILD, which is a descriptive term, patients will rapidly deteriorate and may have an AIP-like presentation. Here, combination therapy, double or triple, can be given. With that, I conclude this talk. And the next on cards is mycophenolate. So I had already asked for a poll on whether MMF should be discussed, and the talk after this shall contain more about MMF, this drug. Thank you very much. Do subscribe, like, and share Pulmonology Read Aloud. Have a nice day.